I want to show you a couple websites real quick that relate to our lecture today. What I typed into Google just right before class, I typed in current guidelines for the treatment of diabetes. And that Google took me right out to the ADA, the American Diabetes Association. And right here they have, this is actually just a news press release, they call it. The ADA releases the 2021 Standards of Medical Care in Diabetes. And then right here you can access the 2021 Standards of Care guidelines. Let's go click on that. I didn't actually click on it to see. But basically what this is, the ADA has its own journal. It's a scientific journal. If you were thinking about doing diabetes for your presentation, this will be a perfect, great APA reference. It's a peer-reviewed journal, and it's the gold standard worldwide for the care of diabetes. So they got a few articles. This is journal volume number 44. They've got the standards of medical care for diabetes. They've got just tons of articles in here. You could grab any one of these articles. If you read any of these articles and actually understood them, you would be an expert on this one topic. You would be truly a diabetes expert. I would encourage you, if you're interested in diabetes, we need more diabetes nurse educators. That's always a need. I just noticed that they have an article called Microvascular Complications and Foot Care. Standards of care. Super interesting. So Monday and Tuesday, I had clinicals on the PCU, and one of our patients, young lady, she was younger than me, and she's going to lose her foot. Why is she going to lose her foot? Because she has type 1 diabetes. And so right here is a whole research article devoted just to how should we take care of that person with a bad foot. How do we prevent that foot from getting bad? What she had done was she stepped on something. She stepped on something and injured her foot. The only problem is she hasn't been able to feel her foot for probably years, and she didn't know she stepped on something. I think she was 40 years old, and she's going to lose that foot because it got infected, and then the infection got into the bone, and that's called osteomyelitis, a bone infection. We just call it osteo for short. Got a bone infection, you got an osteo. Osteo plus diabetes means you're going to get something amputated. It's very tragic and sad, but probably not necessary if we could figure out how to prevent it. And so probably this article talks about that. I haven't read the article, but I'm assuming it talks a lot about how to prevent that from happening. So that's the ADA, American Diabetes Association, a great website. I highly encourage you to check that out. Chapter 25, diabetes and the metabolic syndrome. I would argue that of all the chapters in the book, this one chapter actually will impact your life the most. If you can truly understand diabetes and blood sugar, then it probably had the biggest impact on your own personal life and health, improvement in your life and health. Truly understand, especially the metabolic syndrome. Metabolic syndrome. Diabetes is a disorder of carbohydrate metabolism, and it basically means you have high levels of blood sugar. Glucose is just sugar. Your blood sugar is high because your body doesn't handle or produce insulin very well. Insulin is vitally important to allow the sugar that you eat to go into your cells and feed your cells. Once your body is not able to use insulin or produce insulin, then your blood sugar raises, and that causes all kinds of problems. It causes an increased morbidity and an increased mortality. Morbidity is a word that means you're sick and your sickness is impacting your life. And morbidity technically is an economic measure of lost work days. Lost work days. So if you have a high morbidity because of your disease, you're not able to go to work. Mortality is a little more serious. Mortality means you die. And if you have diabetes, you have twice the mortality rate of someone who does not have diabetes. So that's across your entire lifespan. You have about double the chance of dying any given year if you have the diagnosis of diabetes. You have increased vascular disease, renal disease, neurological orders, blindness, amputation. High blood sugars impact every body system. The book talks about 4 major categories of diabetes. I would say for clinical bedside practice, just think of type 1 and type 2. If you can really differentiate between type 1 and type 2, then that's all you really need to know. The book talks about 4 categories. Wikipedia says there's 6 categories. Every source that you go to gives a different number of categories. But for just practical bedside nursing, type 1 and type 2. When you take an OB class, you'll study gestational diabetes a lot. And so the only real difference is that develops when you are pregnant and then usually goes away, but sometimes it doesn't. So gestational diabetes, if you've been pregnant, you probably remember the oral glucose tolerance test where you have to drink a really sweet Kool-Aid. Technically, it's 75 grams of sugar. You drink that, and then we check your blood sugar 2 hours later. And if your blood sugar is high, by high, over 200, if your blood sugar is over 200, 2 hours later, you have diabetes. But type 1, that is, I think, one of the most catastrophic diagnoses, and usually diagnosed in kids first, but that's an autoimmune destruction of the insulin producing cells in your pancreas. So type 1 does not have anything to do with lifestyle or any factors like that. It really seems to be luck of the draw. Type 1, but of all the worldwide cases of diabetes, type 1 is less than 10%. So most people worldwide, 90% or more of the diabetics worldwide have type 2 diabetes. Usually with type 2, your pancreas is still working fine. Usually for decades, your pancreas is still working fine. Eventually, if you're uncontrolled for long periods of time, your pancreas is going to give up as well. And so because of that, we've gotten away from using the term insulin dependent versus non-insulin dependent diabetes. Type 2 used to be called non-insulin dependent diabetes. But the problem is those type 2 guys, after 20 years of being a type 2 diabetic, then their pancreas also starts shutting down. So they often become reliant on insulin. There's a insulin that they call type 1.5, and that's a bizarre mixture of type 1 and type 2. There's a diabetes that we call type 3 diabetes, which has another name, Alzheimer's disease. Probably in about 2011, they really debated calling Alzheimer's type 3 diabetes because it was very difficult to find a person in a locked memory care unit who didn't have diabetes, type 2 diabetes, and it's made us think probably Alzheimer's is just the high blood sugars affecting the brain, killing off brain cells. Type 1, the pancreas is destroyed. Type 2, insulin receptors become insensitive. They stop working. Those insulin receptors are out in the body on body cells. In the United States, over 30 million people are affected, roughly 10% with type 1, 90% with type 2. The increased diabetes has paralleled the obesity pandemic and the metabolic syndrome pandemic. And the risk factor is a sedentary lifestyle. If you move around for 90 minutes a day, if you just move around, and I love nursing because we move around as a part of our job. If you work as a nurse or a nurse's aide, you put a lot of steps in. If you put 90 minutes worth of steps in per day, your chance of getting diabetes has just dropped 28%. 28% less likely to meet the diagnostic criteria of diabetes. The word polygenic disorder just means that there's a ton of factors that could be implicated. The book does talk about environmental factors. Remember last week we talked about plastic that we ingest, and pesticides and chemicals. All of those things do seem to be one of the factors for why there's more obesity, more diabetes, more metabolic syndrome. Type 1, autoimmune destruction of the beta cells of the pancreas. Type 2, more gradual of an onset in which somebody starts becoming insulin resistant. And that just means basically you've got too much sugar in your blood vessels, and so your cells are freaking out. Every single little body cell is freaking out because it knows, your muscle cell, it knows that if it lets all that sugar into the cell, that sugar will kill that cell. And so the cell membrane, it's smart. It starts shutting down those insulin receptors. It starts shutting down those insulin receptors. So pretty soon, that high blood sugar won't go into those cells, which is actually a good thing. Otherwise, those cells would die. But the pancreas is still working great. And so we still have insulin production, especially early on. The first couple of decades after this diagnosis, the pancreas is still working great. After a while, it does burn itself out though. So just the sedentary behavior, I don't like that word sedentary. How do you even say that? Am I saying it right? I don't know. I would call it the Netflix behavior. The Netflix behavior. Because we live in a world now where you could stream Netflix for 12 straight hours, and not even bat an eye. And it's not uncommon. Many people worldwide live their entire life completely online now. Just completely online. And this is impacting birth rates. It's impacting every measure of health because people aren't moving around. Just getting up and moving around is an essential part of being human. And then obesity goes hand in hand with that. And it's a slow progression. Basically, the carbohydrate metabolism, carbohydrates are anything that is broken down into sugar at the cellular level. It looks like glucose. So all those complex carbohydrates, the pasta is eventually broken down into glucose. And then at the cellular level, that's the fuel for the cells. So insulin moves glucose from the bloodstream into the body's cells. The insulin is produced by the beta cells of the islets of Langerhans. Memorize that phrase. It will always come back to haunt you in nursing school. It seems like I see test questions in every single nursing class about the beta cells of the islets of Langerhans. You should remember that phrase. Langerhans, he was a dude that lived, I think, in like 1867. He was just some guy, got himself a microscope to play with, and he was looking at pancreatic tissue under the microscope, and he identified the beta cells of the islets, and so they named that whole cell after him. He's like, you know what? This is producing insulin. So as soon as you eat, your stomach digests your food, and then it moves into your intestines, to your duodenum. And from your duodenum, bam, hits your bloodstream. And the very first stop of your bloodstream is the liver. So anything that you eat, as soon as it gets digested, moves into your bloodstream, very first stop, the liver. So as soon as glucose hits your bloodstream, the pancreatic cells in the islets of Langerhans registers that. It's like a little blood sugar machine, just like the glucometer that you can check your blood sugar with. Your pancreas measures your blood sugar and it realizes, oh man, I got to start pumping out insulin. And so the insulin secretion really just mimics the glucose level in your body. If you don't have a blood sugar monitor at home, it's sure a fun toy to play with. You can get a cheap $15 blood sugar monitor at Walgreens or Walmart or anywhere. I try to remember to check my blood sugar periodically because I know I'm well on my way to type 2 diabetes. My grandpa had it. So every once in a while, I'll check a fasting blood sugar where I haven't eaten for 12 hours or so overnight. First thing in the morning, check my blood sugar. It's a fun toy and very eye-opening. So insulin facilitates sugar uptake. We eat our carbs. The pancreas secretes insulin. The carbs, which are by now turned into glucose, then enter the body cells. The glucose is used for energy, but it's stored as glycogen. Glycogen is a fancy word for the glucose that is being stored in the cells. Glycogenesis is the formation of glycogen, and this is primarily taking place in the liver and the muscles. For a long time, we really believed, and it might be true, that when you are running a marathon and you hit a wall, have you ever ran very far and then just hit a wall? It might have been, for me, sometimes around the block. Made it around the block and I hit a wall, and it feels like a mental wall. You just hit that wall and you can't possibly go on any further. Marathon runners talk about it a lot because they'll hit a wall like at mile 20 and it just feels like a mental block. They can't push their body any farther. Well, what we've always thought is happening actually is nothing to do with your willpower. It has everything to do with the glycogen stores. Your glycogen stores in your liver. And when you start exercising and your blood sugar starts decreasing as you're running mile and then 2 miles and mile number 3, that glycogen is turning into sugar. That's the last word on this slide, glycogenolysis. Glycogen breakdown, it occurs when blood glucose falls and your body needs energy. Then the idea being with marathon running, you hit mile 10 and you've depleted your glycogen stores in your liver and you hit a wall. And it feels like a mental wall because your brain needs glucose. Your brain needs sugar. And if you run out of sugar, your brain shuts down and then you shut down. I've watched interesting documentaries. Maybe you guys have seen some of these. I'm trying to think of the name of this one I watched recently on Netflix of a ultra marathon runner guy. He was actually trying to do the longest triathlon ever. And he started in Northern Africa and then swam across the Straits of Gibraltar to Europe, and then ran a really long ways, and then jumped on a bike and biked like 1,000 miles or something. It's crazy. Just the feats of human endurance. Crazy. But he pushed himself so hard, at a couple points in time, he fell off of his bike and had basically what looked like a full-blown seizure. He's just seizing. And they were dumping sugar in his mouth. Because those elite triathlon guys, those ultra marathon guys, their body fat percentage is so low, they don't have much glycogen to break down. So that's carbohydrate metabolism and a couple fancy words. But glucose is the energy source. Another fancy word that you will see a lot is gluconeogenesis. And this is part of that process too. If we break that word down, I think medical terminology will help us. Gluco, that just means sugar, glucose or sugar. Neo means new. And then Genesis is like creation. So in the Bible, the book of Genesis talks about the creation of the world. Neo means new. And I always think of that movie, The Matrix. I haven't seen that movie in a long time. The Matrix with Keanu Reeves. His name in that movie was Neo, I think. And that just means new. When our blood sugar starts bumping up high and our insulin is not being produced, we can develop what's called diabetic ketoacidosis. I say we, but only if you are diabetic. And so you might have heard about the ketogenic diet, the keto diet. That's a totally different thing. The keto diet and the ketones for somebody who is not diabetic is totally different. Diabetic ketoacidosis is a life-threatening problem in somebody who has diabetes. Basically, the fatty acids are converted into what are called ketones or keto acids. Has anybody experimented with the keto diet? Any of you guys on Zoom ever messed around with keto? I got a couple of my senior nursing students that are keto right now. They won't stop talking about it. That's how I know. I do play with keto a lot. I try to go keto about every 3 to 6 months. I'll try to bump myself into ketosis. But ketosis in a non-diabetic person is probably really healthy. In a diabetic, it can be life-threatening. One word I want to point out on this slide, I have never pointed it out before because I didn't think you needed to know it. Beta hydroxybutyric acid. If you look at that word, it's talking about ketones, and it is a ketone that we can measure in your bloodstream. The reason I wanted to point it out is Monday at clinical, we had a patient who came into the hospital in DKA. This person was technically a type 2 diabetic, but their pancreas had finally given up. Their pancreas had finally burned out. And so they were no longer producing insulin. They came to the hospital in ketoacidosis, profoundly sick. I think this guy was 50 years old, profoundly sick. The very first lab test for ketoacidosis in the past, and by past I mean up until Monday, was arterial blood gases. We always drew ABGs on these guys to figure out how acidic are they. But now they've started drawing beta hydroxybutyric acid as a standalone lab test at the hospital to measure ketones. I think it's amazing. That's the coolest things happened to me all year. I do have a glucometer at home that checks my beta hydroxybutyric acid. And so biohackers and people that experiment with keto have been doing this for probably 3 or 4 years now. And finally, the hospital has caught up, and we measured that lab test in DKA. Super exciting. I also have a bottle at home of beta hydroxybutyric acid, just in a bottle, and you can buy it off Amazon. People use it all the time to lose weight. Basically, they use it to bump themselves into ketosis, or not technically ketoacidosis, just ketosis. Diabetic ketoacidosis develops in somebody who has no insulin production. No insulin production from the pancreas. A third of kids that are diagnosed with type 1 diabetes first present with DKA. DKA is a critical condition requiring immediate treatment. And they'll present usually with nausea, vomiting, stomach pain, and hypovolemic shock. They come in profoundly dehydrated. The true life-threatening feature of DKA is the dehydration. And why do they get so dehydrated? Because their blood sugar is so high, it's up over 500, might be 800. Their blood sugar sitting at about 800, and the kidneys are freaking out. Your kidneys are just freaking out, terrified that the sugar is so high, so your kidneys start secreting the sugar in your urine. Well, water follows sugar. Water follows sugar. So a super high sugar, you start peeing a ton. And the word for that is polyuria. Polyuria. You pee so much water out that when you come to the hospital, you are in shock. Technically, it's called hypovolemic shock from dehydration. Hypovolemic shock from dehydration is a #1 cause of death in children worldwide. Always has been. We haven't quite got this problem fixed. Hypovolemic shock from dehydration in kids. The reason it's the #1 cause of death worldwide actually is not DKA. It's due to bad drinking water. So as you can imagine, if a kid drinks some dirty stream water that has giardia or amoebas in it or something, they get infectious diarrhea, and they get so much diarrhea they become profoundly dehydrated, and they present with hypovolemic shock. That's the exact same thing that happens in DKA. And so our very first thing to fix these kids is not getting that blood sugar back down. The very first thing we have to do is rehydrate and give them fluid boluses. So we pop an IV in and we give them fluid boluses to rehydrate them and fix the hypovolemic shock. Then our second thing to do is we start looking at getting the blood sugar down with insulin. This slide just really talks about how that ketosis develops. You might have an insufficient intake of sugar, and you get hypoglycemia. Those body cells sense starvation, so then the liver starts working to break down glycogen, and then that glucose from the liver dumps into the bloodstream. You could really use this picture, this slide, to understand the marathon runner. The marathon runner starts getting a low blood sugar because he's exercising too hard. The body cells start starving to death, so the liver starts breaking down glycogen to pump glucose into the bloodstream. Once the liver glycogen is exhausted, then fat starts to be used as a fuel source, which is actually the secret to losing weight. But if not done very carefully and slowly, your body will also start breaking down muscle tissue as well. And so a lot of people that lose massive amounts of weight actually lose muscle as well as fat. It's very difficult to do without losing muscle as well as fat. Do memorize the numbers on this slide. That's really my best recommendation, is just memorize these. Normal blood sugar, 70 to 100, fasting blood sugar. If it's up over 100, well, we've got pre-diabetes. If it's greater than 126, we officially have diabetes. So if you had a blood sugar monitor at home or at work, we did this. I was working one week, and I actually worked out at Gateway Vista for a few years. And one morning, all of us nurses, Saturday morning, we used the glucometer at work to check our fasting blood sugars. Nobody had eaten since the night before. We all showed up to work, and we were actually having a contest. We want to see whose blood sugar was the lowest. But that'd be just a simple thing you could do. And if it's higher than 126, I recommend making a doctor's appointment right away. Figure out what's going on. A postprandial, that fancy word, I don't know why they use these fancy words. Postprandial just means after you eat. So postprandial blood sugar after you eat. If it's greater than 200, well, you better be making a doctor's appointment. Postprandial. I like to take a postprandial nap. After I eat, I want a nap. That would be postprandial. That's the way I use that word. Otherwise, I don't remember the word. Postprandial. There is another hormone that the pancreas secretes, and that's called glucagon. Glucagon does the exact opposite of insulin. Insulin's purpose is to lower your blood sugar. Glucagon's purpose is to raise your blood sugars. So we can give somebody a shot of insulin to lower their blood sugar, or we could give them a shot of glucagon to raise their blood sugar. We have both of those orders on the patient's chart if they have diabetes. But those are also just naturally occurring hormones that your pancreas secretes. Glucagon is secreted from the alpha cells. And insulin secreted from the beta cells. Glucagon. Your book talks about somatostatin. I don't think there's any reason a nurse needs to even know what that word means. You will need to know what insulin is because you'll give it all the time. You'll need to know what glucagon is because you'll give it all the time. But I bet if you asked 100 nurses right now that you know, what is somatostatin? I guarantee not a single one will know. So just because the book has it in there doesn't mean it's important. It is kind of interesting, somatostatin, and how it impacts weight loss and weight gain, but we don't really use it much at the bedside. Glucagon, though, definitely. We use that all the time. This just kind of shows how the glucagon secretion from your pancreas changes based on the blood glucose concentration. It's like your pancreas just has a blood sugar machine built right in. A couple other hormones that impact blood sugars, we actually talked about last week, and they come from the adrenal glands. Cortisol is the stress hormone. If you are stressed out, cortisol starts pumping out of your adrenal gland. And cortisol is notorious for raising blood sugar. We think that's part of the reason for the obesity pandemic. Is the modern Western lifestyle is high stress. High stress. It may not feel high stress to you, but if you are looking at your phone, your adrenal glands are most likely pumping out cortisol just because of how our phone prioritizes bad news. Bad news. And so if we measure just the population average level of cortisol compared to 100 years ago or even 20 years ago, it's much higher now because cortisol is secreted under stressful situations, and cortisol raises blood sugar. So does epinephrine.